Good morning again. Thank you all for joining us. Thank you for joining us, Sister Jackie, Miss Lori. Good morning, everyone. Dr. Dillard, good morning. Miss Yvonne, Miss Chelsea, good morning, everyone.
Hi, Nia.
Good morning, Miss Yvonne.
Oh,
How are
girl.
you?
Good. How are you doing?
Good. Thank you for joining us.
You're welcome. Good luck. I'm going to be in and out because
Uh,
I got another meeting, but I'm
Thank
here.
you so much. All right.
Yeah.
All right. It is almost 11:05, and so we're going to get started. Hold on one second here. Stop the music. All right. Dr. Green, I'm going to introduce you in a few. Okay, it's 11:05, so we're going to get started. Thank you all for joining us this Wednesday for our second Brain Health Series lecture talk. Today, we're going to be talking about navigating racial disparities within healthcare. And so, this may be a bit of heavy content for the group, but I really want to encourage you all to participate. We will have question and answer at the end, and hopefully an open dialogue about our experiences, whether within the healthcare system, being a provider or a patient, so that we can really help to dispel myths and to move forward to help improve and reduce healthcare disparities within the Black and Brown population. I want to introduce some people that will be speaking today before I turn it over to my pastor, Dr. Green, who is our co-sponsor as well as along with Impact and Teachers College, Columbia University. Hold on one second. I don't know who that is. um, one more. Okay. Um, the As I was saying, I wanted to introduce my colleagues from the Neuro Rehab Lab. That is Danielle Kipnis and Alyssa Pacheco. They will be joining us and speaking towards the end of this presentation because they have done some heavy literature review and research into looking into healthcare disparities, specifically in Parkinson's disease. And so they are my co-laborers, and so I wanted to acknowledge them. And thank you, Danielle will be joining me during my presentation. Dr. Johnny Green will start us off, and I'm happy to introduce my illustrious pastor of the Mount Nebo Baptist Church. He will be sharing and kicking off this talk. I'll turn it over to you, Dr. Green.
Thank you, Nia, for this opportunity to partner with you and your colleagues at Teachers College there at Columbia University. Myself, along with our team at MPAC, are more than excited to partner with you on this project. It's a very important project to our community. And when you, along with Dr. Quinn, first reached out to me and gave me the scope of the project, I was very delighted and excited to join you in this partnership because the nature of your project and the discussions and things that you touch upon in your project, the salient uh, points and topics and conversations in this project are things that greatly affect and impact the Black and Brown community, particularly in Harlem and in Washington Heights. It is a known fact that um, we deal disproportionately with healthcare disparities in the Black and Brown community. As you well know, I'm also working with Columbia University in the Department of Social Work and Center for Complicated Grief on a project that's currently uh, we're currently engaged 3 times a week already, and it deals with disparities as well as it relates to the fallout from COVID-19. It doesn't matter what the topic is, whether it's COVID-19, whether it's brain health series or Parkinson disease, something that greatly affects members of our community disproportionately. The bottom line is these issues must be addressed, and our community must be made aware of the pros and the cons, the positives and the negatives, the things that impact us disproportionately, the things that leads to so many unnecessary deaths in the Black and Brown community. So I'm glad to be a part of this discussion today, navigating the racial disparities within the healthcare community. Nia, can you put that slide up? Okay. I want to look and talk for just a few minutes about the history of healthcare for Black Americans. I want to go all the way back to slavery. We all know that America's greatest sin and the original sin of the United States of America is slavery. And unfortunately, for people of color who were brought to this country as slaves from Africa, we are still experiencing the fallout from slavery in the Black and Brown community. To this day, slavery, even though it ended over 200 years ago, a little over 100 years ago, is still greatly having a damnable effect on our Black and Brown communities. Without going into all of the details of slavery, some of the same racial stereotypes and the same racial attitudes still persist and exist today, even in 2021. And it's unfortunate that we have not been able to escape all of the negativity and all of the damnable things that have happened to people of color in this nation. One of the things that we think about is how Black people and people of color were treated as chattel slavery, as property for economic gain. The other day, I was looking at a piece on CNN as they were covering the remarks of Congressman Mo Brooks from Alabama, and he was stating the sacrifices that people have made, et cetera, from his ancestry in Alabama. And I said immediately, he really does not know history. He really has a bad, a false knowledge of history. And I apologize because calls are coming through, but he really has a bad knowledge of history. This nation was built on the backs of Blacks and free work. People of color worked for years and years without economical compensation. And so they were treated as property, not as human beings, 3/5 of human, et cetera, et cetera. Then we think about all of the experiments that have worked to the disadvantage of people of color. Most prominent is the Tuskegee experiment, where men of color in a great number were intentionally and diabolically infected with syphilis. And so now people are skeptical, even as we think in this age of COVID-19, where several vaccines have been created and produced. People of color are apprehensive and less likely to participate and to take the vaccine because they do not want to be a part of a repeat experience being a guinea pig or being used for some kind of laboratorial experiment, et cetera, et cetera. People of color have been treated inhumane. It's just unfortunate. And this carries over into healthcare. You know, we think about economic disparity. We think about all sorts of injustice, racial injustice, which Black people and people of color have experienced in this nation. And here's what I want to say: it has created trauma in our community. There's a lot of trauma. There's a lot of undiagnosed trauma. A lot of the fallout, a lot of things that we see happening in our community, it is the result of what Nia and her colleagues have labeled RBTS. And this trauma is serious. We should acknowledge it. We should deal with it. And I'm glad to be a part of this project because they so saliently address this issue. And it has led to so many devastating consequences. And like I said, I'm glad that MPAC could co-sponsor this and be a part of this. I'm thankful for Dr. Mensah and others, her colleague, Dr. Quinn, for asking us to be a part of it. And I hope that our time of sharing today and all of the helpful information that Nia will share with us in her presentation will serve as a foundation to help us to ascertain more information, more knowledge, and to be more, not so much reactive, but responsible people in the community as we seek to help our community overcome some of the disparities that so greatly impact us. Thank you, Nia.
Thank you, Dr. Green. So, navigation, by definition, is the process of accurately ascertaining one's position, planning to help follow a route. So, Webster goes even further and defines it as the science of getting ships, aircrafts, or a spaceship from place to place, especially the method of determining position, course, and distance traveled. So this is important because I wanted to stick with the term navigating because we need to talk about where we've come from, and Dr. Green has done a great introduction, so eloquently explained the past and how we got here, right? And so I do want to talk about that and talk about how it affects some of our decisions, but also how the system and the effects of racially based traumatic stress is now being really investigated and talked about among Black and Brown individuals. So, just to give you a little bit of a definition about racially based traumatic stress, or RBTS, I'm not going to go through what my pastor already shared with you, but it refers to the mental and emotional injury caused by encounters with racial bias and ethnic discrimination, racism, and hate crimes. Any individual that has experienced an emotionally painful, sudden, and uncontrollable racist encounter is at risk of suffering from a race based traumatic stress injury. In the US, Black, Indigenous people of color, BIPOC, which is a common phrase to describe this group of individuals, are the most vulnerable due to living under a system of white supremacy. So we're just going to call it out and be very clear about where this stems from. And so these experiences of race-based discrimination can have a detrimental psychological impact on individuals and their wider communities. And we're seeing that today in the statistics. We will show you the data and we will talk about how we've gotten here. And then we really do want to focus on what we can do to improve and reduce health disparities. We're going to talk to individuals that are not healthcare providers. And then I'm also going to identify and shed light into what we can do as health providers to help reduce these disparities. And just to be clear, racial based traumatic stress will look like PTSD, which is post traumatic stress disorder, and it can result in depression, anger, reoccurring thoughts of the event, physical reactions such as headaches, chest pains, insomnia, hypervigilance, low self esteem, and mentally distancing from the traumatic events. So some of all of these symptoms may be present in someone with RBTS, and symptoms can look different across cultural groups. And so Dr. Green talked about our past, and we all know the past often informs our current challenges. So there's the lingering power of the past. And when I talk about the past, I'm not only talking about slavery, but I'm talking about the ongoing disproportionate care for people of color. And so as a result, parental family influences from these horrible memories of racist health practices and habits are passed down through the generations. We're talking about generational information about horrible experiences that are now being passed down to our young people because of the mistrust. And healthcare professional perceptions are something that are very common. And so that includes racialized medical practices, i.e., Black people have a greater tolerance for pain, or there's creatine levels to determine kidney function, and disbelief as a result of the race. And so we do have to dispel these myths. This is a photo that I adopted from my dear aunt. But this picture depicts James Marion Simmons, who is known as the father of gynecology. This is a picture as they were experimenting on Black women slaves without anesthesia. And these were based on the assertions that Black people didn't feel pain, and therefore did not need to have alcohol or ethanol or anesthesia to help sedate them when they went through these laboratory or surgical procedures. Eugenics is another area in the research world, which by definition is the study of how to arrange reproduction within the human population to increase the occurrence of heritable characteristics. This term became something that we wanted to dispel or discredit in the scientific world around World War II. So during the 20th century, this became something that in the US that we did not want to continue with, mainly because the Nazis used it in order to justify their treatment of Jews, disabled people, and other minority groups. And so this picture specifically depicts the thoughts during the early 1900s, where there was the beginnings of state eugenics programs to basically sterilize people of color. And the thought was that these people were not of equal value and expendable. These practices in the United States were legal in 31 states until 1970. It's not that long ago. And this last picture I wanted to share was of Fred Simmons, who was a participant in the Tuskegee study. Not going to go into too much detail because Dr. Green shared a little bit about this horrible injustice, where from the years of 1932 to 1972, the U.S. Public Health Service conducted a study of the effects of untreated syphilis in Black men in Macon County, Alabama. This study, there was not a cure for syphilis in 1932, but in 1940, there was the development of penicillin, and this was not provided to these study participants. And therefore, these 399 men with latent syphilis and more than 201 men that were participate in the study after this, the initiation of the study, their families and their children watched their demise to syphilis, which was a treatable disease. And again, this went on until 1972. Okay, so now let's talk about where we are today. So this is not my quote. This is Dr. Evelyn Hammonds, who is a Harvard professor. She says there has never been any period in American history where the health of Blacks was equal to that of whites. Disparity is built into the system. Okay, so when we talk about the current state of Black health, we do need to acknowledge where we're going. Telehealth is one of the as well, during a pandemic, it is the number one way that we're increasing health access. If you're not able to go in a clinic, you should be able to get on telehealth if there's something that's not too that doesn't require immediate attention. So this is projected to increase, and I know amongst African Americans, we are less likely to use telehealth services. Also, based on the evidence from the Affordable Care Act, it really helped to improve access to health care for people that were uninsured. But most of those individuals utilize clinics in urban and rural hospitals. And many of these hospitals in some of the county system do not have as many specialties or experts in every field to help reduce maldiagnosis or to help with adequate care. Also, emergency department continues to be the primary physician for many people of color. There specialized medicines and trials, and we'll talk a little bit about this specifically in Parkinson's disease. The research is not inclusive, mainly because many people of color are not interested in participating. And I'm going to ask you guys that question in a minute. And then we continue to have worse health outcomes. If we're not able to investigate what will help among individuals, and I'm not saying be a guinea pig, but to also to find out how experimental drugs to help treat cancer, to help reduce the progression of Parkinson's disease, we don't know. And if it's not applied in our community, we're not going to have access to some of these groundbreaking treatments. And so we will continue to have worse health outcomes until we figure out what we can do to bridge the gap. And then again, the stereotypes that are race-based in medicine. And so there's a continued legacy of distrust. People of color receive less care, often worse care, lower rates of health coverage, communication barriers exist, and then the racial stereotypes and bias. And I'll talk a bit about implicit bias at the end. Okay, mistrust. Many studies suggest theories for why disparities exist, but few have conducted research. Existing studies note higher perceived barriers to healthcare for Black people as a result of mistrust, implicit bias, which is our unconscious bias. And all of us have this based on our experiences or what we've been told in the healthcare system, which positively affects white patients but negatively affects Black patients, meaning that many healthcare providers may have a bias against people of color. And that, as a result, reduces their ability to properly care for people of color. And this mistrust of researchers and physicians include a feeling of stigma and perceived racism. Now I'm going to turn it over to Danielle.
There we go. Need to unmute myself first. All right. So hi, everyone. So there is disproportionate access to care from a system level. And I'll get a little bit more into these levels that we've kind of looked at and categorized for our research. But the system level I like to think of is the level that everything else functions underneath. And so some of these access barriers are payment to care. So there's a lack of insurance, but then also a lack of quality, access to quality insurance. And then that comes from a place of policy, right? So who has access to that quality healthcare is biased. Part of this reason might be because you don't have healthcare for all. And so how much you can pay for healthcare determines the quality of your care. And then there's also a problem with access to care and providers. And one of these reasons is because of a referral system, right? So you need to get a referral from your doctor. And there's been a lot of research into how effective this referral system is in getting you to the right care and getting you to early treatment. You can advance the slide.
Now I'm muted. Okay, so this is a question I have for the group, and you can use your features and just raise your hand if you don't feel comfortable speaking. I would like to know how many of you guys have ever participated in a research study? You can put your reactions up. Okay, good. We have a few people. You can put a thumbs up. Okay, good. And okay, good. And actually, I'm going to be more specific. How about a medical research study, maybe including experimental drugs or some kind of exercise program? Okay, so the thumbs have come down a little bit there, and that's understandable. Okay, I participated in the study a few different times. One time I was actually, it was during the birth of my daughter, and there was a new blood pressure medicine that they were looking to investigate, and I had some high blood pressure issues, and so I signed the informed consent and participated in the study. And so when we talk about research representation, the numbers don't lie. There are few studies, or there's limited, I should say, limited numbers of African American individuals, Hispanic individuals, and and Native Americans as well. And a lot of it has to do with access, but it also has to do with this layer of mistrust. So I'm going to turn it back to Danielle because I want her to talk specifically about the data that her and Alyssa found when looking into Parkinson's disease. And if you remember from the last lecture, Dr. Lori Quinn talked about the importance of early detection and getting in at the first signs of some level of tremor, or if you're feeling that there's some change in your mental status. And so I turn it back over to my colleague.
Yeah. So again, right, the research is showing that research is simply not accurately representing all populations. So a lot of the studies that we've looked at, a lot of the studies that are out there have a majority white sample population. And there's also been studies that show there actually is a significant willingness of Black and Hispanic populations to participate in research. So while mistrust is definitely a factor and the history is a factor, there are some other reasons. And this is really important and a problem because if studies are only focused on one population, we simply cannot accurately generalize the results from that study. So some other reasons that we might be getting this underrepresentation come from perhaps a lack of access to a specialist. If you don't have access to a specialist, that's going to lead to lower diagnosis rates for certain diseases, especially with Parkinson's disease. And then we're kind of pulling from these databases of people who have a disease to get our research participants. So there's an misrepresentation there. And then there's also an underreporting of disability, which does come from mistrust. But then if we go back even further, that's really coming from this history and systematic racism that we're seeing. And ultimately, all of this underrepresentation is leading to inaccurate estimates of prevalence, incidence, and risk factors. So some of the research is suggesting that we want to shift our research focus a bit to qualitative studies. So qualitative studies, you can kind of think of it as non-numerical work. So it seeks to better understand a phenomenon, and it can be based in firsthand observations and focus groups and interviews. And so if we shift the research focus a bit, we might be able to better appropriately measure concepts, and also perhaps create more individually targeted analytical methods. So again, right, we base a lot of our measures on norms that have been developed on white populations. And so that needs to shift a little bit. And so the current state of healthcare disparities research is that there is a fair amount out there that has detected that these disparities exist, but there really isn't too much on understanding, reducing, and eliminating. So we're going to want to shift that. You can go forward, Nia. So how do we get accurate healthcare information? So in the research field, we call access to information health literacy. And there's a definition of this: the degree to which an individual has the capacity to obtain, communicate, process, and understand basic health information and services to make appropriate health decisions. And so it's really, really important to keep in mind here that when we talk about health literacy, we are not talking about level of education or reading ability. So that's not what we mean by literacy. It's really just the ability of an individual to access the information, and is it written and provided in a way that can be understood. So again, racial disparities in healthcare are coming from disparities in health literacy. And this is going to lead to less people being less likely to develop trusting relationships with their doctors, increased hospitalization and emergency care, decreased use of preventative measures, and then ultimately increased mortality rates. And so really what we need to see is providers putting out appropriately written and targeted materials that are for and available to everyone. So putting it all together, I've created this visual of, it really needs to be larger, at least a little small on my screen, but from a glance, I don't know if it can be any larger. Oh, yes, perfect, great. So you can see, right off the bat, it's quite complicated, and I'll speak to the complexity, but just to orient you a bit here. So this is showing disparities in research, in mostly specific to Parkinson's disease, although there is a lot of overlap and generalization that we can take away. So it's important to note here that the size of the bubbles and the darkness of the bubbles is not indicative of how important or impactful that factor is, but rather just how much research has addressed that thing. And I'll come back to that in a moment. So just to orient you a little bit about what the colors all mean, we have 4 different levels you can see on the bottom right, and I'm going to go from the bottom up. So the individual level in purple is basically the individual person or patient. So that can include characteristics like income, education, and then that closest social circle of family and friends that's going to influence behavior and beliefs. Then 1 level up in orange, we have the community level. So this is going to be settings in which individuals have social relationships. So maybe schools or religious communities, neighborhoods, and broader social circles. Then in yellow, we have providers. So this is going to be the care team of doctors, clinicians, therapists, pharmacists, et cetera. And then finally, we have that system level in pink. And again, that's kind of what all of this interacts under. So it's the political and socioeconomic environment that everything else can function under. So coming back to the complexity of this, and you kind of look at it and you're like, whoa, there's a lot going on there. And I think that that's important to note, right? That this really is a very complex issue, and it's not just stemming from one place. So it's not just stemming from mistrust or just stemming from low health literacy, but there is interaction within these levels and between levels. And so to address the problem, it's going to take a multi-level approach. The other thing that I think is important to note in this graphic is that you can really see where the research has focused, right? And one of the aims that our team is doing is to try and figure out where there are gaps in the healthcare research and understanding these disparities, in particular for PD, for Parkinson's disease. But so as you look at this, right, what do you think about the importance of the larger versus the smaller bubbles? Is, for example, low health literacy really the most impactful thing, or maybe is it something that's a little smaller, like, I don't know, down here is income or inaccurate, information. Maybe those are more important, but less research is focused on them. And then also, if you look at this, are there things that are even missing, right? So maybe there's something that you've experienced or people have experienced, and the research isn't even getting at it. And again, going to those qualitative research methods might help us to get a little bit more to what could be missing. Finally, I think that you can really see that there's a big top-down effect, right? You can see there's a lot of arrows coming from the pink level and affecting others. So for example, if you're looking at mistrust, which we talked about, so that's going to manifest at the individual level, but really look at all the pink and yellow arrows that are coming at it. So it's really a child of many other factors. So yeah, we can move forward. And actually, I think that's all for me, and then I'll come back in a bit. And I'm happy to share this with anyone if you're interested to kind of take a closer look.
Thank you, Danielle. I think that image is pretty impressive, and thank you for doing the literature review to really support your findings. So this is a slide that I borrowed from an older presentation. And so I don't know if you remember the Simpsons, but, and just sticking to navigation, are we there yet? Who can answer that question? No, none of us are there yet, right? Mainly because if you can look at the year we had, 2020, and even just looking at last week, we have a long way to go, even within our own nation, right? And so I did have a quote that I actually had with this slide, and we've had a lot happen since February of 2020. But I did want to quote this article that said, first, it's important to note that overt expressions of prejudice and negative racial stereotypes have declined substantially over time, as norms condemning bias and endorsing racial equality have become stronger and more widespread across the population. I will say this, I think with the outpouring of protest, the outpouring of the awareness of police brutality, I do believe that as a nation, we are getting to the point where we are publicly condemning some of these racial stereotypes. But are we there yet? The answer is no. Let's look at the numbers. So, when looking at these numbers, you can see healthcare coverage 2017, 10.6% versus 5.9%, comparing individuals of color, okay, to are uninsured, I'm sorry, and 44.1% government have government insurance, okay? When looking at mental health, 2.8 per 100,000 African American women died by suicide. In 2018, 3.8% of all individuals of African Americans report serious psychological distress. So these are pretty high numbers. When the leading cause of death in African Americans is heart disease, cancer, and accidents, African Americans have the highest mortality rate for all cancers. 80% of African American women are overweight or obese versus 64% of white women. In 2017, 12.6% of African American children have asthma as compared to 7.7%. We all know the Bronx has the highest incidence of asthma in the nation, right? In terms of children with asthma. 2017, 42% of African Americans over 20 suffer with hypertension versus 28.7% white. So that's double the number in Caucasian individuals. So, and these statistics are consistent with the Cigna Health and life insurance. So, when looking at healthcare professionals, we do know we have a layer of mistrust. It would be easier to kind of dispel some of the myths with having people of color in the healthcare profession. But when looking at the numbers, 4 to 5% of physicians, of all physicians, are African American, and less than 7% of medical school graduates are African American. Currently, 50.7% of medical school enrollees are women. 4% of these women are active physicians are Black, and 2% of these women are Black women. When looking at nurse practitioners, we have 73.3% that are white, 12.6% that are Black, and 17.3% that are Latinx. Data suggests that patient-provider racial and gender concordance lead to better communication, lead to better trust. So we need to work on really increasing these numbers so that we can have better health decisions. In terms of Parkinson's disease, Blacks are half as likely to be diagnosed with Parkinson's disease than whites, possibly due to underreporting. We don't know. But Black have the highest disease severity, followed by Hispanics in Parkinson's disease. I cut this slide in because as a physical therapist, I work with individuals with disability. And so 26% of all adults will have a disability or will classify themselves as having a disability. When looking at the stats per group, American Indians, 3 in 10 will have a disability. In terms of Black individuals, 1 in 4 on this call will have a disability. 1 in 5 Caucasian individuals will have a disability. 1 in 6 Native Hawaiian or Pacific Islanders, Hispanic 1 in 6, Asian 1 in 10. And now now we really need to focus on what do we do now, right? When looking at the possible solutions. So I'm going to turn it back over to Danielle to show what the research has shown.
Yeah, so hi again. So currently in the research, the most used strategy to try and combat these to combat these disparities is to change how educational material is delivered to minority populations. And this essentially involves attempting to modify individuals' awareness, knowledge, and attitude of a health issue. So sometimes that has come up as providing supplemental materials such as transportation vouchers. But it also is really in changing the way the educational material is given. So maybe it's more culturally friendly, like in the form of a story. It's a little more entertaining, and that has been shown to change attitudes on healthcare and seeking healthcare. There's also a big push for technology, so mobile apps and web-based portals. And the research suggests this could be a cost-efficient means to increase patient-physician access, right? You can kind of just log on to your portal, talk to your doctor fairly easily, and this might increase patient adherence and also help with individualized care. It is important, though, that minority populations are actually involved in the development of these technology advances so that it is appropriately targeting the needs of each community. And then in strategies for attempting to increase research participation, there's been attempts to combat economic and time constraints. So again, giving stipends and also creating a schedule that's more based on the participants to combat cultural stigmas, fear, and mistrust. There's been a lot with faith-based education programs, so really very similar to what we're doing now, teaming up with churches to essentially give information in what feels like a more, hopefully more comforting environment, something that is known. And then also some community spaces, so barbershops and jazz festivals. And then again, on mobile health, there's been a push for that. And then in combating research bias, one of the big problems is also our registries. So registries are kind of like these big lists of people that might have a certain disease, and those tend to not be very diverse. So if we're always pulling from the registries that aren't diverse, then how is our research going to be diverse? And so finally, there is a big push for what we call community-based participatory research, CBPR. This is a method of research that relies on collaborative relationships and equal partnership between the researchers and the researched to develop, implement, and analyze a study that will be helpful for both parties. So this can be used to gain deeper insight into communities' needs and experiences. It often involves focus groups and peer navigators that might relate personal experiences. And currently it has been proven to be the most effective method for minority recruitment in research. So what's missing? You might notice that a lot of these possible solutions that have been tried have really focused on the individual and the community. But if we go back to that disparities visual, it was multi-level, right? And a lot of it was coming from provider and system levels. So we really need to develop multi-level interventions, and we need to start targeting those system and overarching policy the overarching policy in order to create more effective interventions. So that's kind of where we're heading with our current research.
Thank you, Danielle. Now I just want to kind of speak to the healthcare providers, and in addition to everyone else on the call, what can we do? The truth is, it's time for us to step up. How can we do that? Increase minority retention and recruitment, implement equitable practices, start really looking to self-reflection, self-awareness, and therefore acknowledge our own implicit bias. And so I talked a bit about implicit bias, but I'm going to go more in depth about it. So this study was done from 2000 to 2006. It was a Harvard study that utilized implicit association tests. It's a test where you basically determine good or bad based on the picture that comes up on the screen. Anyone can go to the website and take this assessment to get an idea of your implicit bias. Are you more biased towards different skin hues? Are you more biased to women versus men? And it's very interesting, but more than 2.5 million completed this test. and associated self-report measures on 17 different topics. And what they found was that there was bias across the board. Every group or a race that utilized this test had some layer of bias. And some of the ones that were the highest level of bias was not only race, but it was bias based on gender, age, sexual orientation, ethnicity, religion, and disability. And so this was published in Nozick et al. 2007. So let's talk about specifically among healthcare providers, right? The Institute of Medicine documented that the simplest that from the simplest to the most technologically advanced diagnostic and therapeutic interventions, African American individuals and those in other minority groups receive fewer procedures and poor quality medical care. We've already talked about this, but Burgess and colleagues set forth an evidence-based recommendation for healthcare providers, and I highly recommend any healthcare provider on the call to really look at this, because she provided great examples on ways to improve reducing these biases. Okay, and the truth is, she unveiled that many healthcare providers across all levels in healthcare have stereotypes based on patients' race, class, sex, and other characteristics. And these stereotypes typically occur outside of their own conscious awareness. Okay, and that and providers interact less effectively with minority individuals than with white patients. And lastly, I wanted to share an article by Dr. William Hall and his colleagues, where they conducted a systematic review that looked at conscious and unconscious implicit bias among healthcare providers. And this one included physical therapists, which is why I wanted to share it. From the hundreds of papers, only 15 systematically looked at the effect of implicit bias on patient-provider interaction, treatment decisions, and patient treatment adherence and patient-related health outcomes. And what they found when looking at this study that included physicians, nurses, nurse practitioners, and physical therapists, they found that, and they also utilized the implicit association test that I mentioned before. And they found that most of the studies found a low to moderate level of implicit bias. They also found that in pediatricians were not providing the appropriate level of pain medication to children based on health disparities. So basically, people of color received less pain prescription that would have been more appropriate. I mean, they should have had more pain medication, but they receiving less based on the outcome and looking at the medical records of these individuals. And so it's important to note that basically there's moderate levels of implicit bias, and this was presented in 2015. So again, just in summary, implicit bias is any unconsciously held set of associations about a social group. We all have them. It can result in the attribution of particular qualities of all individuals from that group, also known as stereotyping, and it's the product of learned associations and social conditioning. So since we all know we have these implicit bias, what can we do? What is your response? I already mentioned self-reflection. The way you self-reflect is by identifying your bias, understanding what you think about when you go into the medical office. And as patients, we have them as well. Sometimes I may feel like I'm not going to be heard. Sometimes I may feel that I need to just go along whatever the physician says or not ask any questions. And so I need to really be reflective in that and try to develop a relationship with my provider and with my patients to make sure that we reduce biases. We also need to deliberately combat preconceived prejudice, and this is on a systematic level. Burgess and her colleagues recommended methods of trying to basically reduce these preconceived prejudice. That includes developing your own interventions, right? She encourages to enhance internal motivation, not just only taking a course because your work is requiring you to take a DEI initiative, but really looking into ways that you can reduce bias. She also recommends enhance your understanding of the psychological basis of bias. Why do you have this bias? Is it because you had some racial trauma? Is it because of something that was seen on TV? Or is it something that was passed down generationally? And that is in all racial groups. Also, we need to enhance providers' confidence in their ability to successfully interact with socially dissimilar patients. I don't know why sometimes we still deal with this, especially in the healthcare system. But again, we need to get to relating to one another, realizing that we are all humans, that we all really have the same desires to prosper and to take care of our families and to make a living for ourselves, and to really get past some of these issues with connecting with people of different races. And specifically speaking to healthcare providers, it's not an excuse because you're not used to dealing with people of color in your friend circle, your social circle, that you avoid interactions in a medical setting, or you avoid not having deep conversation to address medical issues. We also need to enhance emotional regulation skills specific to promoting positive emotions. So if there's an emotion that you feel when you're encountering someone from an opposite race or another race, you really need to figure out why that emotional trigger is there. And that's why I really wanted to start with the racial-based trauma, because it is something that we are now becoming more aware of. We knew it was there all along, but to have a definition and a title, it really does help to for people of other races to realize that this is something that people of color engage in on a regular basis. This is a conscious thing to think that, oh, maybe I'm being treated this way because I'm Black. That is not a thought that other races may experience on a daily basis. And so it's important for healthcare providers to keep that in mind and to make sure that their emotions are in check before interacting with people from different groups. She also recommends that we increase perspective taking and effective empathy. That means looking at the perspective of someone you're working with and putting yourself in their shoes. And so we all need to do that a lot more. And lastly, she suggests that we improve the ability to build partnerships with patients. And so it is more than just prescribing medication. It is more than just that initial interaction. It is developing a partnership. And I do believe, just piggybacking on what Danielle said about research, if we are going to really increase research participation with people of color, there needs to not be a divide with research and participant. We all need to be working together to solve a common problem, and that's why we're all here today. So let's get into it, as Tammy Roman would say. And so here are references. And I know we're running closer to the end, so if there are any questions, I did hope that we would have some time. I'm going to turn it to Alyssa to moderate the chat room, chat box, and see if we have anything in there.
Yeah, anyone that has any questions, please post in the chat, and I will post it to I will say the questions to the group, and then we can maybe get a little discussion going.
I also want to acknowledge, thank you, Mrs. Jackson Diagni, for the information you included. There were a couple links in the chat about the implicit bias test, some information about race and ethnicity, and she also shared one on the COVID. One of the researchers that developed one of the COVID vaccines was African American.
Okay, we have a couple questions coming in. The first one I'll read. Can you describe what you mean about underreporting as a factor in disparities of African-American Parkinson's patients?
I'll turn that over to Danielle.
Yeah. So there have been a couple studies that conducted some interviews and focus groups with not just Black populations, but also Hispanic and Asian and some Native American. And It kind of looked at generally perspectives on aging and how people kind of view certain symptoms, particular to Parkinson's disease. For example, if you noticed a tremor, would that be something that would bring you to a doctor, or would it be something that you just kind of saw as part of normal aging? And so some of these studies have suggested that Black and Hispanic communities are less likely to report symptoms to a doctor than white, and I believe Asian, but I would need to double check, populations. And so the exact reasons for this are unknown. It could come from cultural places, it could come from the mistrust, it could come from systematic racism. I mean, again, it's all complex, but that's what we mean by underreporting. Basically, would you go to a doctor to report a certain symptom?
Hi, that was my question. This is Erica. And I kind of thought that's what you were referring to. And the reason why I brought that up was that I think sometimes as healthcare professionals, we put a little bit too much on a patient to diagnose themselves versus actually being the diagnostician ourselves, like diagnosing the patient when that patient comes in for their annual or whatever like that. And I think even as a healthcare provider myself, I experience this when I go into my physician. A lot of times I'm asked, are there complaints on a yearly exam, when during that visit, I barely get a physical exam from that person. It's really a heavy reliance on serum studies, looking at my cholesterol and things like that. So I think we as physicians or clinicians have to do a better job of just doing the basics for every single patient. It's our job to kind of recognize those things in patients, because like you said, literacy may not necessarily be the same across the board, or knowledge of certain medical conditions in every single population, which may be cultural. And so I wanted to kind of make that point too, just based off of what you said, is that it's not always, we have to stop putting so much weight in the patient to tell us, and be better at seeking those things out ourselves.
Yes, that is really great insight. Thank you.
Thank you, Dr. Bill.
Could I add, hi, my name is Dr. Shah. I'm actually a neurologist and a movement disorder specialist, and I'm so excited about, this conversation that you all have had. And Erica, to piggyback on what you're saying, and the underreporting of symptoms. I'm a movement disorder specialist, so I see patients with Parkinson's disease. And in my experience, even, we often see, unfortunately, patients that are minorities, Black and Hispanic patients who have been struggling with symptoms for many years before they even come to see a specialist. Whereas their white counterparts often say, I started to have tremor 2 or 3 months ago. And I think your point is really well taken, that we rely too much on the patient to be able to identify symptoms. And, I've been thinking about this lately a lot, about language that we expect people to use. I think even during our training, we're taught that, does the patient shuffle? Does the individual have tremor? And I think a lot of times people don't use those words to describe the difficulties that they're having. They might just say, my walking is off, or as Danielle pointed out, some people just think that this is normal or part of normal aging. So I totally agree with you that I think we really need to take the responsibility that the examination and assessment is our responsibility. And if individuals don't come to us with exactly the right words or don't ask us the right questions, that's the only way they're going to get to be diagnosed appropriately. So I think we need to start changing the way we think, and really put the emphasis on our exam, because to be quite frank, in terms of Parkinson's, at least, I think you can make a diagnosis without any history. You can just examine the patient and come to conclude if they have the disease or not. But of course, the history is important, and we want to hear from the individual, their story and how they're affected. But I think we need to get away from, expecting the individual to come to us with their complaints. And I think another challenge is that often people are seen by their primary, like you said, and there's so much for the primary care providers to do that they can't always, make the right referrals. And sometimes people prefer to see just one doctor. I know it's a lot to expect a person to navigate this very complicated healthcare system where you see your kidney doctor and your main doctor and a neurologist, and you're supposed to keep it all, in check and figure out, well, this doctor told me to take this medicine and someone else told me to take a different one. So I think that's another aspect of it. But anyways, I think this is a great conversation that we're having. And thank you so much for allowing me to participate.
Thank you, Dr. Shaw. I also wanted to give, I believe Juliet had her hand raised. I just wanted to see if you wanted to ask your question. You can unmute yourself. Or you can type it into the chat also. While we're waiting on that, I just wanted to mention, if you're interested in receiving the information from this presentation, you can email Nia directly and she will send a PDF version out. Nia, if you could maybe just write your email address in the chat so that people can contact you with further questions. Oh, I see that Juliet said it was a mistake. Okay, no problem.
No problem.
Does anybody else have any questions?
I just wanted to, before we wrap up, and we'll ask if anybody has more questions, I just wanted to also thank, we had 2 neurologists on the line, so I just wanted to thank Dr. Shaw for collaborating with this endeavor, who works up at Columbia Medical Center, and also thank Dr. Erica Diller, who will be doing our last brain health lecture, where she will be sharing about signs of a stroke. She is based out of Memphis, Tennessee. And so she's also my college roommate. So I have to throw a shout out there. And so she will be presenting on February 10th, if I'm not mistaken, at 11 a.m. I'll turn it back over to you, Alyssa.
Okay, perfect. Thank you, Nia. I'm trying to see. I don't think I saw more questions. Nia did just post her email address in the chat. It is also available on the thank you slide you see here. And if anybody else does have any questions, you can also feel free to unmute yourself and ask. I don't see any other hands raised. So. Oh, and we also, there was some conversation in the chat regarding COVID and the vaccine. We can maybe have a little discussion about that if people have thoughts or questions or concerns. Can feel free to ask.
I know I've had a couple of conversations with members of my community. I did go ahead and take the Moderna COVID vaccine because I do have contact. I see one patient right now, and I thought, after weighing the risk and looking up some of the information about the research, that it would be a safer bet. Knowing that we have a majority of people of color that have died from COVID, I of course encourage everyone to investigate the vaccine and the options that are becoming available. I know that Johnson & Johnson is working on another strand of the vaccine, and so we may have more options come summertime. But I'm thankful that Libby brought up that there are some Black researchers involved in development of these vaccines, and my thoughts are anything that can help reduce the risk of this virus that has been really just devastating to our community may be of interest to individuals that will have access in the coming months. Any thoughts from the physicians on the line?
Sorry, just needed to unmute myself. Yeah, so I had my first dose as well. I just, on a personal note, I am nursing. I just had a baby. I am of childbearing age. I know that that's a concern from some folks. I'm familiar with the data, and I think that as Nia said, I would also say that, the benefits outweigh the risks for me. I think certainly this is a great topic to have maybe another conversation about and present some of the data to this group, and allow some time for real questions and answers. I know among the healthcare workers at Columbia, there have been many sessions to help educate our colleagues. So I think the same should be done. I know, for instance, Cornell is hosting an event later today about some of the vaccine hesitancy, I think, that minority community members are feeling. And given the background of this talk, I understand where that's coming from. So I think it's just imperative that we all educate ourselves so that we can protect ourselves and our families. I think taking the vaccine is really about thinking about your own health and the health of your family. So I'd be happy to discuss that further with Nia. Maybe we can plan a further discussion to talk about more details. But yes, I did get the vaccine myself. My second dose is in a week, or 10 days. And I did experience some minor side effects, soreness of the arm. I felt tired, a little nauseous, a little bit of headache, but I'm feeling fine now. And I think that I'm looking forward to getting my second dose so that I can feel that I'm protected and my family is also protected, since I do see patients face to face.
We did have another question regarding the vaccine that I did want to address to the physicians on the line. They were wondering if, now that the vaccine is being widely given out, if the same brand of vaccine is not available for your second dose in your area, should you take whatever is available?
I would say no. The two vaccines, though they're similar in terms of their makeup, they're mRNA, which is messenger RNA. It's like a type of DNA that, and just as a side note, mRNA vaccines have been being developed for many, many years, for decades. So the actual development of the vaccine was not kind of novel in any way. It was something that's been done for a while. But that being said, each of the vaccines is different. So if you were to, for instance, start with the Pfizer vaccine, you would want to get a booster with the Pfizer. And similarly, Moderna, then you would want to get the booster with the Moderna. In terms of the logistics of the vaccine rollout and how that's going to play out, I'm not sure. I'm not privy to those conversations, since there is more widespread distribution and they're not withholding those doses to try to get everyone their second dose. But I still think that the plan would be for people to get the same brand.
Thank you, Dr. Shaw. If there's no further questions, I just wanted to thank both Nia and Danielle for that wonderful presentation. If you do have any further questions, you can contact Nia or any of us on the thank you slide you see there. Otherwise, we have another brain health talk. Nia, do you want to give the information on that? I can't remember the date off the top of my head.
Oh, that's fine. It's February 10th, same time, same place. We will you do need to register again for the final session, but again, Dr. Erica Dillard will be presenting on signs of a stroke. And I will, if anyone's interested in the presentation, I will update. There's a typo here on Alyssa's email, so I will make sure that I will put the appropriate. Alyssa, can you put your email in the chat? And before we go,
Yes,
first of all, thank you so much. That was my mistake. Thank you all
No
for
worries.
being here. I want to acknowledge my advisor, Dr. Lori Quinn, who is also on the line and who presented last time. And I really hope you are able to make it on February 10th, because the material that Dr. Dillard will present is very important, and to acknowledging the early signs of a stroke, and really gives a great clear understanding of what a stroke is and why it's important to make sure you stay healthy and keep your brain health to the best status that you can have it at. So I will turn it over to Dr. Green for final remarks. And again, thank you so much for your time. Dr. Green?
Thank you, Nia. This has been a most helpful. This has been a most helpful seminar, and the information presented will benefit so many people, not just members of the community, but even educators and medical professionals as well. And certainly we want to thank you for your dedication to this cause. We want to thank Dr. Quinn, and we want to thank all of the presenters today for being a part of this. And we bid you Godspeed.
Thank you all. Have a good day.
Thank you.
Bye.